Metabolic morbidity, we have a contribution of the disease. Patients are psychotic, might have an increase in cortisol levels, but also our medications have a big impact. The pharmacological mechanisms between our drugs differ, therefore also the pathways into metabolic risk are different in these medications, and clearly we have lifestyle factors, both related to the illness, but also when you're sedated or you have EPS, your motivation to actually do more exercise is down in the basement. Yeah? So we have another effect how healthy lifestyle can be altered adversely, or when you don't have or remove the sedation, you can become more active. Okay, so I think this is all clear to you. We need to make up some time. In terms of first episode, there is a debate. I mean, how much is there the illness, how much is the medication? When there's a long-standing debate, the answer is always both. That's true. But what's the major contribution? Most likely it's more the medication than in the beginning in naive patients. They do have more metabolic problems despite the fact of being maybe normal weight like the general population. But this increases within weeks, as you saw, going with metabolic syndrome from 1 out of 5 to 1 out of 3, 1 out of 7 to 1 out of 3. That is not the illness, that is the medication. So it's both. And the weight gain differences are large. There are only 3 antipsychotics that have no short-term, no significant increased risk of weight gain compared to placebo. Now this shifts and there's no weight-neutral antipsychotic. All of them can cause weight gain, but they level off earlier. And obviously the penes have the biggest problem with the weight gain. So haloperidol, ziprasidone, or lurazidone looked the best short term. And we have fat mass increase. That's also a big problem. But look at the UFEST first episode study. No more than 10 weeks lifetime exposure to antipsychotics. Haloperidol and ziprasidone looked similar at 6 weeks in the network meta-analysis. But then when you continue, too much dopamine blockade, reducing hedonic value, most likely is not good for weight gain either. These people creep up, and the best weight potential was with ziprasidone. But look at where olanzapine is, like 10 kilograms, and that's even with dropouts. Yeah? So we have a big difference. Amisulpride, 7 kilograms, quetiapine, 7 kilograms, and haloperidol, 5.5. So none of these medications is weight neutral, but some seem to have better long-term capacity. Now, the leptin story is not that important. It's just that most likely there's leptin resistance that can be part of the antipsychotic weight gain. And there are other receptor types like 5-HTC, histamine, and dopamine are all implicated in the weight gain. But we don't know exactly how antipsychotics cause weight gain. Now, there may be protective antipsychotics when you add them together. So there are rat data suggesting that aripiprazole added to olanzapine neutralizes the weight gain. And we have even an antipsychotic polypharmacy meta-analysis published last year in World Psychiatry, where that was one of the side effects that was decreased with polypharmacy. Weight, sedation, and prolactin when you add a partial agonist to a full antagonist. When you add 2 full antagonists together, you have less insomnia because you have 2 sedating agents, but you have more prolactin elevation. And 2 antipsychotics did not really do a better trick than one in blinded studies, but in open label studies there was an effect. Maybe that's expectation. Maybe these are the sicker patients that would otherwise not get into a study. So this is aripiprazole, but there are also data with lurazidone. So looking at olanzapine weight gain, lurazidone alone no weight gain compared to vehicle, but olanzapine plus lurazidone also no weight gain. Yeah? So there may be some combinations where some of the effect is neutralized. We don't know exactly how. In humans, we know that's true. For the rat data translates into human data. For lurazidone, there hasn't been an RCT yet. Now, obviously, we have different approaches to optimize the cardiometabolic health. Starting with a lower risk agent is the number one. First, do no harm. It's so much easier not to gain weight than to lose weight. We all know that. Yeah? So try to not have people gain too much weight. You can maybe switch to a lower risk agent, but that can be destabilizing, and switching needs to take into account the pharmacology. you come from a more weight gain inducing, sedating, anticholinergic agent to aripiprazole, lurazidone, ziprasidone, you shouldn't stop the first drug immediately. You need to do a cross titration. You need to slowly come down on drug A while you're going up on drug B. And with lurazidone, the starting dose is the working dose, 40 milligrams, but you may have to go higher. Also, when you do a switch, your job is to keep the dopamine blockade similar. So if somebody is on 20 of olanzapine, 6 or 8 of risperidone, don't tinker around with 40 or 80 of lurazidone, 10 of aripiprazole. You know you need to go to the upper package insert dosages. So you need to go to most likely 160. Yeah? So do a 1-for-1 switch in your mind and move up, especially in these medications that are better tolerable. And then adjunctive treatment, best evidence for metformin and topiramate. Topamax is Dopamax. It can actually worsen some cognition. We just have a patient right now who complains of that, where we added topiramate. Another patient has dysesthesia. Those are the 2 side effects that you can see with topiramate. But more recently, GLP-1 agonist, that is an anti-diabetic drug. We actually published the liraglutide data, has even a better weight-reducing effect than metformin. 5.5 kilograms versus 3. So that's pretty strong. But we need to get oral treatments, and this is at the moment still experimental. And obviously, lifestyle changes also shave off about 3 kilograms over 4 months, but only in motivated patients who sign up for these studies. And it's hard for us to exercise. How much harder is it for patients who are ill and who are on medications? So the British Association of Psychopharmacology has these methods, but you have them all in your mind anyway. So switching can be powerful. Let's look at the 6-week study where there was roughly equal efficacy between olanzapine and lurazidone for schizophrenia, but there was a 1.5 kilogram increase with lurazidone versus a 4.5 kilogram with olanzapine. 3 kilo difference in just 6 weeks. But then when patients were switched to in the open label phase from olanzapine to lurazidone, they were able to actually, on average, to lose that weight, especially early on, and went down to the weight that they would have gained just on lurazidone. But you may say, but somebody has responded to olanzapine. I don't want to risk giving up that efficacy. They responded to olanzapine. Well, let's look at efficacy. At 6 weeks, they were roughly equal. In purple, you can see the switch from olanzapine to lurazidone, and in the yellow from lurazidone to, or orange to lurazidone. So you can maintain in most patients the stability, but be careful how you switch. Don't do it too quickly. Now, weight gain and BMI is one issue when it comes to cardiovascular effects, but it might actually adversely impact psychiatric outcomes. So there are now more and more accumulating data to that effect. And this is from a study we did in 1,000 consecutive patients at Hillside Hospital in New York. And we asked the simple question, who is readmitted within a year? What predicts that risk of increased readmission? So we had basically a quarter of the 1,000 were readmitted. And we found predictors that were not new. Schizophrenia higher than non-schizophrenia, clozapine treatment because they're refractory, shorter length of stay, pushing people out, gets them to rebound. And actually, ECT was protective. So people who didn't have ECT for their mood disorder that was severe rebounds more. But we want the biggest independent risk factor for readmission, much higher odds ratio than all the others, was actually higher BMI. We did not anticipate that because people who are readmitted usually are those that are non-compliant. We didn't have a measure of compliance. This was a chart review. But when you are non-compliant, you should lose weight. Despite that, the higher BMI people were readmitted. And that's most likely because they have more inflammation and oxidative stress, and that translates into worse illness. Now, we can't prove that. We need additional studies. We now have another data set in adolescents where the same is shown, that the readmission was associated with higher BMI. This is from the Healthy Active Life group. We need to not just screen, but intervene. We want to get people to the green, but we need to also monitor and see where are they. Many of these cardiovascular risk factors are not visible to the eye. So bearing the body in mind is important.